Today's Friday Forum is made possible by Bank of the Cascades, CenturyLink, Family Care Health Plan, Miller Nash, The Standard, and Stoll Reeves. Good afternoon, and welcome to the City Club of Portland Friday Forum. I am John Horvick, City Club President, and I'd like to welcome members and guests alike. Those of you who join us today at the Sentinel Hotel, and those of you listening on OPB Radio or watching on Portland Community Media. Today, our speakers will discuss maternal and early childhood health, but first, some announcements. The generous support of City Club's corporate and media partners ensures we put on the best civic programs week after week. I'd like to thank our media partners, including Oregon Business Magazine. Our current Friday Forum sponsors are Bank of the Cascades, CenturyLink, Family Care Health Plans, Miller Nash, The Standard, and Stoll Reeves. We are grateful for your support and commitment to City Club's mission. Please join me in a warm round of applause for all of you. City Club members approved the report, Rising Rates and Customer Concerns, Assessing Governance of Portland's Water and Sewer Utilities. The final vote was 256 in favor, 13 against, and 2 abstentions. The 95% majority surpassed the threshold necessary for the creation of an advocacy committee. So be on the lookout for more information about turning these recommendations into action. Next week, we're pleased to welcome Bonneville Power Administration's new administrator, Elliot Mainzier, to the Friday Forum. And as you know, City Club is launching a research study on healthcare and homelessness. To continue the discussion on the Friday Forum stage, Nan Roman, President and CEO of the National Alliance to End Homelessness, will join us on April 4th. You can learn more about these and other club events, purchase tickets, and become a member on our website, pdxcityclub.org. Join City Club in live tweeting today's event. You can follow or mention us at PDX City Club, and be sure to use the hashtag CityClub in your own tweets. We'll be having a Q&A session with our speakers at the end of today's program. Members, please come to the microphone to ask your question. And for all our audience participants, please locate the index cards in the center of your tables and write your questions on them during the forum. We'll collect them prior to the start of the Q&A. And now to our program. Important steps can be taken to promote healthy pregnancies and babies. Today we'll learn about the challenges involved and some of the ways Oregon is responding. Dr. Shelia Martin will discuss the report and findings of the State of Maternal and Child Health, prepared by the Institute of Portland Metropolitan Studies. She is the director of IMS, as well as the Population Research Center, a service and research institute in the College of Urban and Public Affairs at Portland State University. As IMS director, she serves as a portal to the university's knowledge resources for the community. Her research and teaching interests include economic development and technology, economics, and policy. Michele Stranger-Hunter will focus her talk on the one key question approach to helping ensure Oregon women and families are having pregnancies that are wanted, planned, and as healthy as possible. She is the executive director of the Oregon Foundation for Reproductive Health and NARAL, Pro-Choice Oregon. Michele has a master's in science and education, has worked in healthcare policy and politics for over 30 years. For the last 9 years, she has developed programs and successfully advocated for policies to improve women's access to reproductive health services. State Senator Elizabeth Steiner Hayward will discuss maternal and child health programs that support healthy newborns, infants, and young children. She is a family physician at OHSU, where she works to provide primary care to both children and adults. She is the immediate past president of the Oregon Academy of Family Physicians and currently serves as the director of the OHSU Night Cancer Institute Breast Health Education Program. Senator Steiner Hayward was appointed to the Oregon State Senate in December 2011, representing Northwest Portland and Beaverton. And so without further ado, please help me welcome our speakers to the stage.
Thanks, John, and thank you all for being here today. I wonder if you've ever noticed that when people talk about the birth of a new baby, the first thing they mention is how healthy the baby and the mother are. They might say things like, "We welcome our healthy new baby boy," or they might say, "The mother and baby are doing great, they're both healthy." Or they might say, "It was kind of a tough labor, but they're both doing fine now." The reason that we talk about this so much is because it's so important to our future health and to our quality of life that we start with a healthy birth. So today, my job is to give you a brief overview of the state of child and maternal health in the metropolitan region. And I hope you've all had a chance to pick up the handout in the back of the room, because I'm going to be speaking very briefly from the statistics contained in this brief report. And these indicators come from Greater Portland Pulse. Greater Portland Pulse is a project that we put together in partnership with Metro, the City of Portland, WSU Vancouver, Multnomah County, the Institute for Sustainable Solutions at PSU, and the City of Beaverton. They were all partners, as well as many other people who helped us come together and decide what's really important in our community for us to measure and to track over time. And so we put together those indicators. We track them on our site at portlandpulse.org. But Greater Portland Pulse is really a lot more than just a website. It's really the start of a conversation. We put the information out there in order to encourage people to talk about it and to understand why we're moving in the direction we're moving, why things exist the way they are. And so today's forum is exactly what we envisioned when we put together Greater Portland Pulse. And I have to thank Sam Adams, because when he was mayor, he gave us a great deal of support for putting together Greater Portland Pulse. So getting to the indicators now, we're going to start with low birth weight babies. And the rate of low birth weight babies is an important indicator to track, because babies who are born at low birth weight have an increased risk of infection, long-term disability, developmental delays, and even death. And low birth weight can have a really long-term impact on a child's health. The trends in our region indicate that rates of low birth weight babies in the 4 metro counties span a low of about 54 per thousand in Clackamas County to a high of about 63 in Multnomah County. And the rates have varied quite a bit since 2000, but the rates are lower today than they were in 2000 in both Clackamas and Multnomah counties, but higher in Clark and Washington counties. And when we break the data down by race and ethnicity, we find that the only group that has really gained in terms of low birth weight, that is the only group of women who have a lower incidence of low birth weight babies today, are white non-Hispanic women. So every other racial group is having an increase in low birth weight babies. And African Americans and Native American women are most likely to have children who are low birth weight. So the next indicator that we pulled together is about child immunization. And this is important because immunizations protect children from diseases, but they also protect the people around them. And many diseases that were once common in the United States have been controlled or eradicated by vaccines. And they're also, I learned from talking to Senator Steiner, an indicator of whether or not young children are getting access to health care. And I imagine she'll want to talk about that some more later. So on average in the United States, about 72% of children by the time they're 2 years old have been fully vaccinated according to recommendations. But in our region, the number is around 68%. But more importantly, the data show that these percentages have been falling over time, with the biggest drop in Washington County. So next I'm going to turn to chlamydia, not something we usually discuss over lunch, but it's important. It's important because it's one of the most frequently reported STD in the United States, and symptoms can be very mild or moderate, and so it's difficult to diagnose, and many people don't even realize that they have it. Chlamydia can harm fertility in the mother, and it's associated with higher risk of low birth weight babies. And as we discussed earlier, that presents a number of risks to the child. If left untreated, chlamydia in a pregnant woman can be passed on to the baby, and those babies can have a higher risk of early infant pneumonia and conjunctivitis. Now, unfortunately, the rates of chlamydia are increasing in all of the counties in the metropolitan area, and the increase has been most noticeable in Washington County, where it's risen about 83% from 2001 to 2013. And rates of chlamydia are highest among African Americans, Hispanics, and young people from the ages of 15 to 24. Finally, I'm going to talk about the teen birth rate. I think it's pretty easy to understand why tracking teen birth rates is important. Teen mothers and their babies face increased risks to their health, and they also face decreased economic opportunity. Teen mothers are less likely to graduate from high school, and girls who were children of teen mothers are also more likely to become teen mothers themselves. Now, when we look at trends in teen birth rates, this is the good news story of the day. Teen birth rates peaked in the mid-1990s and have fallen since then across the entire region and for every racial and ethnic group, although Hispanic women are still more likely to give birth as teens than other ethnic and racial groups. So with that positive note, I'm out of time, and I'm going to pass the podium over to Michele Hayward. But I'm going to encourage you, if you're interested in what? I'm sorry. What? I'm sorry, but I'm going to encourage you. Did I say your name? So I'm going to encourage you to go to portlandpulse.org and explore the data in greater detail.
Thank you. We hadn't thought about the reality that both the senator and I have SH names. I'm Michele Stranger-Hunter. So on behalf of the Oregon Foundation for Reproductive Health, I want to thank you for this opportunity to share our concerns about the state of maternal and child health in Oregon and suggest an Oregon solution. Thank you to the Institute of Portland Metropolitan Studies for putting together this data report. There is one sentence in the data report that if I could, I would put in flashing neon lights for you. Pregnancy-related outcomes are influenced by race, ethnicity, income, and access to health care. So that just in case you are feeling good about what you just heard, I need to tell you things are good if you are white, middle income, and intended to be pregnant. Today, I'd like to focus our attention on the state of maternal and child health if you are a woman of color, if you are poor, if you are rural, and you did not intend to become pregnant. If you are an African American woman or American Indian woman living in the Portland metropolitan area and have a baby, your baby is twice as likely to die in the first year. And as the report showed, women of color have somewhere between a 30% and 60% greater risk of having a low birth weight baby. So what would our future look like if we in fact made maternal and child health a top priority? Not for some, but for all women. The Oregon Foundation for Reproductive Health envisions that all pregnancies will be planned, wanted, and as healthy as possible. Unintended pregnancy, whether mistimed or unwanted, have a greater likelihood of infant and maternal illness. We know that the babies are more likely to be born preterm, low birth weight, have developmental delays, and die in their first year. The mothers are 3 times more likely to live in poverty. They fall into poverty with the unintended pregnancy. The costs to our communities in terms of women's lives and their children's lives are extraordinary, as well as the costs of additional health, education, and social services. I gotta admit, it is hard for me to accept that for the last 30 years, I have been quoting the same shocking statistic. Almost half of all pregnancies are unintended. It's hard to understand how something that has such a profound impact on the physical, emotional, and mental lives of women, children, and our communities would not be a top priority. So why is unintended pregnancy such an intractable problem? I can assure you it's not because birth control doesn't work. 65% of the women at risk of becoming pregnant use birth control consistently and correctly, and they only represent 5% of those unintended pregnancies. 19% of the women at risk use birth control inconsistently or incorrectly. For example, in Oregon, birth control prescriptions are refilled on average every 38 days. Now, women have a 28, 30-day cycle. There's a gap there. 16% of the women who do not want to become pregnant don't do anything at all. They have an 85% chance of having an unintended pregnancy. Low-income women, women who live with incomes below 200% of the poverty line, have a 5.5% greater chance of having an unintended pregnancy. We wanted to do something about this problem. We traveled the state of Oregon, speaking with hundreds of primary care clinicians, and with few exceptions, we consistently heard, I don't talk to women about birth control. Well, I mean, I would if she asked me, but my patients don't come here for that. They go somewhere else. They go to an OBGYN or a family planning provider. And honestly, when you're talking about, let's say, 30 minutes outside of any one of our cities, talking about getting yourself to an OBGYN or a family planning provider is a significant challenge. So we discovered a factor, a huge contributing factor to unintended pregnancy, is that the healthcare system is designed to make women go to two different places for their health care. One for their reproductive organs, and one for the rest of our body. Honestly, women are so well trained, know that they're supposed to be going somewhere else. They don't bring it up in primary care. Less than 14% of women say that they ever brought up a reproductive health issue with their primary care provider. And we also know that fewer than 30% of the women go to a women's health specialist. Women's health care is siloed, fragmented. Reproductive health, compartmentalized, pregnancy-related care, and the rest of our care, primary care. The fragmentation comes up in some pretty obvious ways. A woman goes to her primary care clinician complaining of symptoms that are in fact related to her birth control method, but she doesn't know that, and the primary care clinician doesn't know that because she hasn't listed birth control as a medication because it's birth control. It's not medication. Or a primary care clinician responding to the woman's complaints gives her an antidepressant or an anti-anxiety medication that actually could have a toxic effect on fetal development. But the conversation about, well, now, if you're really, if you should be getting pregnant, if you're thinking about that, I'd really need to wean you off this medication and get you on something else. The conversation doesn't happen. And many women have chronic conditions that must be treated and minimally stabilized before she conceives. Asthma, diabetes, hypertension, cardiac disease, dental caries, oral disease, all have a significant impact on the pregnancy and on optimal birth outcomes. This means the fragmentation in women's health care actually leads women to enter pregnancy in poor health. with potentially avoidable threats already exercising their influence. We must recognize and address this unnecessary gap. We must increase women's access to reliable information, services, and referrals so that she has optimal health, planned pregnancies, and optimal birth outcomes. Preventive reproductive health care, a term actually coined here in Oregon, includes preconception care and contraceptive care, care provided to women before she conceives. Preventive reproductive health care should be offered proactively, routinely, and often. Now, prenatal care is absolutely essential. It's essential for monitoring the development of the pregnancy and mitigating any problems that arise. It is essential but not sufficient. Preconception care is necessary in order to increase the maternal and child health in this state. So, we know what to do to get healthier pregnancies. We know what to do to prevent unintended pregnancies, but we still have a system that is divided, siloed, fragmented. That's where Oregon's exceptionalism comes in. Because we're Oregon, we did not accept that. Because we're Oregon, we can do it differently than the rest of the country. And we actually discovered, are you ready? We discovered a rocket science solution. And that solution, ask the woman. When women go into primary care, when they're seen by a healthcare provider, that provider needs to include in the health assessment the woman's pregnancy intentions. One key question is the solution. One key question: would you like to become pregnant in the next year? If yes, great. Let's make sure you don't have any pre-existing conditions, and here's your folic acid, because we know folic acid prevents birth defects. If no, great. What are you doing for contraception? And are you satisfied with it? Is it working for you? And if the woman is unsure, okay, how about some contraception until you are sure? Alternatively, we recommend you act pregnant before you become pregnant. If a woman is saying, you know, I'm okay either way, again, act pregnant before you become pregnant. Help women understand that the status of their health is actually critical as they conceive. Help women know what behaviors and what services they really need to access before they become pregnant. One key question equally supports women who want to be pregnant and those who do not. We have the full endorsement and support of every primary care organization in Oregon. The Oregon Medical Association, the Nurse Practitioners of Oregon, the Oregon Academy of Family Physicians, the OBGYNs, the emergency room physicians, the osteopaths, the naturopaths, the Oregon Public Health Association, all see this as a reasonable, easy solution. Almost like, how come we didn't think of that before? We know when we tested this at Richmond Clinic, at OHSU Richmond Clinic in Southeast, women loved being asked the question. And clinicians who were initially concerned that what's going to happen when I ask this question and I open Pandora's box, they found actually that it was a very effective question, that really only 30% of the women did need follow-up care in some other version, but 70% of the women were settled and really appreciated having that question asked. We know from having since implemented this outside in downtown Portland, Washington County Public Health Clinics, Hood River public health clinics, soon to be at the Community Health Center, Wallace Medical Concern, soon to be throughout the healthcare delivery system in Jackson and Josephine counties. It will be at every point of service, whether you are a private practitioner, a public health program, a human service program, or a dentist. I gotta love this, dentist. We know clinicians don't have time. We would suggest to you, we can't afford for clinicians not to take the time. And if I haven't convinced you already, let me give you just one more piece of our lens. Women are fertile for 35 years. On average, we have 2 children. On average, we are pre-pregnant, pregnant, or postpartum for about 5 years. Doing the math? That means for 30 years, we are trying to prevent an unintended pregnancy, month by month. What do you call chronic? Healthcare transformation has focused our attention on chronic conditions, right? Early identification, intervention to prevent the acuity of sickness. I would strongly suggest to you that preventive reproductive health has many of the same characteristics of a chronic condition, and one deserving of proactive, not reactive, monitoring and oversight by primary care, and deserving of all of our attention. Right now, in addition to all the work that's happening here in Oregon around one key question, this idea, born in Oregon, was published in a peer-reviewed journal last July and has garnered a great deal of national attention. We now have providers in 12 different states that are in some phase of developing or implementing one key question because it works. It is a way to improve maternal and child health without increasing costs, but having a tremendous impact so that women can play the full and vital role in the social and economic fabric of our communities that I know we all want. So, the next time you go to your clinician, ask them, are you asking one key question? Thank you.
Thanks, Michelle and Sheila, for some really great start off. It's a little tricky being asked to back cleanup after 2 really, really smart, effective women, but I'm going to do my best. It's a particular pleasure to come. I've been listening to City Club forums since I moved to Oregon in 1991, and it's the first time I've had the opportunity to join you as a speaker, and so thank you very much for the invitation. I want to start, actually, by framing the question at a more 30,000-foot level. You all know the parable of for want of a nail, right? For want of a nail, the shoe was lost. For want of a shoe, the rider was lost. And it kind of goes on from there. And for want of a nail, the kingdom was lost. Early childhood, pre-pregnancy, and those first 2 years of life, the first 1,500 days of life, starting a year before the baby's even born, that's the nail. That is the nail that builds the kingdom of a healthy community. And I want you to think about this that way and frame what Sheila's told you, Sheila's told you, and what Michelle's told you, and what I'm going to tell you in that vision. And I also want you to frame it in an economic perspective, okay? Leaving aside that this is the right thing to do part, because I think we can pretty much all agree about that investing in our youngest, most vulnerable Oregonians is the right thing to do. From an economic perspective, it's really, really smart. Let's take, for example, immunizations. Sheila mentioned that an immunization rate in Oregon is, on average, 67% of 24-month-old, 2-year-old babies who should have received a significant number of immunizations that are evidence-based and proven. 67% are fully immunized by the age of 2. Immunizations, every dollar we spend on immunizations gets us $10 back in prevented illness, in prevented disability. Some of you are old enough to remember when polio was around. My mother tells stories when she was growing up about not being allowed to go to any place where there was public open bodies of water when she was a child in the summer because of the risk of polio. I didn't grow up worrying about that. Most of you didn't grow up worrying about that. But there are parts of the world, and now parts of our country, where people are going to have to worry about that again because immunizations aren't happening. And when people get polio, or when they get measles, or chickenpox even, which we think of as a benign disease but puts children in the hospital, or whooping cough, which kills babies, then the cost to our society, both from a social justice perspective and from an economic perspective, is enormous. And as Shelia mentioned, when we know that children aren't getting immunizations, that means that they're not having contact with the health professionals who can and should be screening them for developmental delay, for social and emotional issues, for growth delay, for speech delay, all of which interfere with early learning. You hear a lot these days about our early learning programs and talking about kindergarten readiness, right? That's a big buzzword these days. It's really hard to be ready for kindergarten if you can't speak clearly. It's really hard to be ready for kindergarten if you don't know how to play well with others and you haven't gotten the interventions you need to help. It's hard to understand why reading is important if you live in one of these lower socioeconomic families, you've had maybe 25 hours of one-on-one time reading from a picture book compared to the 1,100 hours of one-on-one reading time if you come from an upper socioeconomic class. 25 compared to 1,100. That time spent one-on-one with vocabulary enrichment, the association, things like that. And those are the things that can help our children succeed. And when do we do that? When they're the youngest. It is never too young to read to a baby, right? You think, well, what's a 3-month-old going to do? But it's the vocabulary. We estimate that by the age of 3, children in lower socioeconomic families have heard on average 3 million words, upper 11 million words. And it's because parents don't understand. They haven't ever been taught. They weren't brought up in families themselves where they had done to them or they do for their children what I would imagine every single one of us who have children does. We go to the supermarket and we say, oh, look, we need to buy cereal. Are we going to buy the cereal in the blue box or the red box? Well, let's look at the prices and see. And this is the same cereal, but this comes in a bigger, we do the math, right? And we talk them through all of this. But the cool thing is, there are easy ways to solve these problems. Studies done as far back as the 1960s. There's a great article in an academic journal about education in 2003 that talks about studies done as far back as the 1960s, where they actually went in and intervened and did parental coaching in their homes on an ongoing basis as part of a longitudinal home visitation program to improve parenting skills. They closed that gap. The vocabulary gap that we know exists in children at age 3 almost disappeared. Now you can say, well, it's really expensive to send people into people's homes. It is. But when you think about the fact that vocabulary at age 3 predicts reading at grade level at 3rd grade, and reading at grade level at 3rd grade predicts on-time high school graduation, and on-time high school graduation predicts the likelihood of interacting with the criminal justice system, then it seems pretty cheap, doesn't it? Right? I mean, a year and a half ago, when the governor, in 2013, when the governor opened the 2013 legislative session, one of the things he said is something many of you know. It costs about $10,000 a year to keep a child in school. It costs $30,000 a year to keep the person in prison. What's cheaper? And what's better for the kind of Oregon that we want to have? And we know that these programs work, whether it's through relief nurseries, which we have and which we're continuing to grow and expand across the state, which do interventions with families where 50% of the parents themselves come from homes where they were abused or neglected. So how do they know how to be good parents if they've never had a model for that? Why should we expect somebody to know instinctively how to be a good parent if they didn't have good parents, if they aren't well educated, if they don't understand the value that their child gets from something as simple as engaging them in grocery shopping, right? That's not very expensive, and we know it works. But let's think also about simple things like vision, right? If you're going to kindergarten, you have to be able to see the words on the page. You have to be able to see the letters on the blackboard. You have to be able to put the fine motor things together that you're trying to learn. Really tough to do that if you're not seeing well. And we know that babies should really probably have their vision checked, or at the very least be being checked for major things like lazy eye, amblyopia, on an ongoing basis. I do it as a family doctor at every checkup, every well child check, starting when the baby's born, all the way through until kindergarten, all right? And when they're little, that's every 2 months, right? Because we know that if we catch that early, we can fix it. It's very simple to fix it. And then we've got kids with good vision, and then they're better able to learn. Or if we need to get them glasses, we get them glasses. And Michele mentioned oral health. Well, a lot of people don't know that it's not a good idea to leave a baby in bed with a bottle of formula. Because what happens? They get cavities in their baby teeth. Well, you can't pull their baby teeth because they're not going to be getting regular teeth for a while. And even if you did pull them, then their regular teeth won't develop well, and their jaws won't develop, and then you've got a whole host of other problems. So then you have to take 2-year-olds and put them under general anesthesia to treat their cavities. That doesn't sound like a good plan to me. It doesn't take a lot of coaching to help make sure that that doesn't happen. And a kid who's got dental pain isn't going to be learning well, whether it's in Head Start or kindergarten, right? So we have to start thinking about this in a very holistic way, in a very matrixed way. Some of you have been in my office in the Capitol, and you've seen that in the middle of my desk I have this little kid's toy. And if you haven't seen it there, you've probably seen one before. It's a bunch of little wooden bars with balls at the end, and there's elastic connecting all these little bars. And if you push on one of them, everything else moves. That's how we have to think about this. This is a matrixed process. Immunizations, lack of immunizations is an indicator of two things: lack of access to health care or misinformation about the benefits and risks of immunization. Now, we can deal with some of this. For example, on March 1st, a new law that we passed back in 2013 took effect that changes what it takes to get an exemption from having your child fully immunized. Thank you. Thank you very much. As a chief proponent of that bill, thank you. I really appreciate it. We have districts in this state with a 75% under-immunization rate. 75%, people. New York City right now, which doesn't have as bad an under-immunization problem as we do, is having a measles outbreak. When I was in medical school, almost 30 years ago, it was something that they brought every medical student in the building to see if we saw somebody with measles. It was that rare. Now, it's kind of like the flu. Not quite that bad. I'm exaggerating a little. But it's going to get there if we don't fix this problem. And when we have them there, we need to make sure that the family doctors, the pediatricians, the nurse practitioners who are seeing these patients are well trained. So, for example, the Oregon Pediatric Society is doing some great training with programs called START with providers around the state, and the Oregon Academy of Family Physicians is partnering with them so that we make sure that the primary care providers who are seeing these children are screening their vision, are doing the actual developmental screenings, are engaging them in a new ready-to-read program, right? In my practice, we have a shelf full of books, age-appropriate, and every time a child comes in, no matter what their socioeconomic status, they go home with a book. And we talk with parents about reading to their children and why it's important as part of routine well child care. Well, that doesn't have anything to do with their physical health now, but it has a lot to do with their physical health 25 years from now. Because it's really tough to be healthy if you're not well educated, right? How do you read a nutrition label? How do you understand about how to interpret scientific evidence about whether an intervention is a good idea or not if you can't read, if you haven't been trained to understand data at all? And that starts with reading to 2-month-old babies. So as we think about this problem, and I'm trying to keep an eye on the time, because there's so much more I could talk to you about. I mean, this is really, honestly, I could talk for an hour and a half about this one, because it's something I'm so passionate about. This is a place where we can make a huge difference in the state. I've talked to you about immunizations. I've talked to you about dental care. I've talked to you about vision. I've talked to you about vocabulary enrichment and reading. I've talked to you about developmental screenings. All of these things are things that babies respond to and that are not expensive to implement. We got to front load the system. You know, there's a reason that an ounce of prevention is worth a pound of cure has been an adage in one form or another for millennia. And that's because it's true. It is much cheaper to do the upfront prevention than the downstream cure. So as you go out of here today and you think about the data that you've heard, you think about the one key question, you think about some of the points that I've made about this, I want you to look around where you are and in your environments and think, where is the upstream potential? Where do we need to be looking upstream to make a difference in what we're seeing now? How do we prevent some of the problems we're seeing now by doing the upstream work? And I think you'll find that no matter what you do on a day-to-day basis, there are ways to do that. And that Oregon really has to make a commitment to doing that upstream work. And we are. We're changing the way we deliver early childhood services. We're changing the way we think about lifelong learning in this state. We're changing the way we do early care with the preconception work that Michele talked about, and I've been honored to be a part of really since its inception here in Oregon. And the developmental training that we're doing with family doctors and pediatricians across the state. There's enormous potential. And we've got to find that upfront money. But honestly, in the long term, it's totally worth the investment. Thank you so much.
Thank all of you. And now, if you have a written question on an index card, please hold it high so City Club staff can collect it from you. We'll now take questions from the floor. As always, we invite members to the microphone to ask their question. Asking questions at the Friday Forum microphone is a benefit of City Club membership, and membership is open to everyone. Before asking your question, please identify yourself as a City Club member. Please ask only one question and ask your question as succinctly as possible.
Hi, Felisa Hagan, City Club member. My question is, roughly 60% of births in the state are born on the Oregon Health Plan. What do you think the state's role is specifically in maternal health as well as sexual health and pregnancy prevention?
If I can, I'll start with that. I think it's huge. And one of the things that makes me really happy about the work that Michele and her colleagues have been doing is that one of the indicators we're using for CCO effectiveness is the percentage of women of childbearing age who are on appropriate contraception. And we're using that as a measure to track whether our CCOs are doing their jobs, our coordinated care organizations that are providing health care for all OHP patients. And we're also using indicators like whether babies are immunized properly, and indicators like, are they getting the appropriate developmental screenings, things like that. So I think there's a huge role for the state to make sure that we're holding our CCOs, our healthcare providers, responsible for the things that we know make a difference in the long-term health of Oregonians.
If I may add to that, let me underscore. Felicia, you just said 60% of pregnancies are covered under the Oregon Health Plan. This is not about women on the Oregon Health Plan becoming pregnant. In fact, 18% are on the Oregon Health Plan when they conceive. Women fall into poverty with that unintended pregnancy. The state has an enormous vested interest, therefore, in supporting preventive reproductive health services, preconception care, contraceptive care, and encouraging that among all public and private providers.
Carol Witherell, City Club member, thank you so much for coming. This is so important, and it connects with so many other issues around the globe as well as in Oregon. I was intrigued by your charts in the report that's available over there, and wondered why they capture race, but they don't capture income level differentials. And it just seems to me that we really need to look at the effects of rising cost of living, cost of health care, declining income for the majority of our citizens and families, and the effects on access and affordability in all of the areas that you've spoken to, including contraception, prematernal, maternal, and early infant and early childhood care. Are those broken down in another report that we can look at online by chance? And can you respond to that intersection of race and class or income levels, poverty levels?
Well, we do know that there is a strong relationship between race and ethnicity and income. And so all of the factors that influence quality of life with respect to income are also influenced by race because of that correlation. As we went through the Greater Portland Pulse process, we had a committee of people who were examining the data and the way we broke down the data and made recommendations about how to make sure that we were representing as fully as possible the experience of many different kinds of people. And we did our best to do that, but we are always hamstrung by the availability of data. And sometimes we can't put data on the website because it's just not reliable, because the more times you slice and dice a piece of data, the less confident we are that it's actually accurate. And so we do our best to be true to what the committees told us was important to them, and also not giving us so much data that we don't know where to start to try to interpret it. However, we are certainly open to taking a look at certain issues in more detail, and if you want to go to the website or call me, we can certainly talk about how to obtain better detailed information about specific issues.
I want to add one thing, if I could. The last two questions reminded me of one thing I didn't talk about, which is maternal mental health. And that makes me think about the fact that we have to be careful about making assumptions that all the problems related to unintended pregnancies or problems in the first 2 years of life are limited to people of lower socioeconomic status. I've been very open and very public about the fact that I live with chronic depression, and I take medication, I'm stable, and I treat it just like diabetes. I had severe postpartum depression with my first baby, severe. And it took months for my doctor to recognize. Now, it's 18 years ago. We're a lot more comfortable about this now. But I was a physician. I was getting care from one of my practice partners, and yet I could barely stand the look of my baby for the first 2 to 3 months of her life. Now, fortunately, eventually I got the help I needed, but that's not true for every mother. And we know that maternal mental health issues are not confined to any particular socioeconomic group or racial or ethnic minority. We know that domestic violence, which severely influences children's growth and development and their mental health, is not confined to any one group. So yes, there is absolutely a significant disparity that's caused by poverty and lack of education, but it's not exclusive to those groups, and we have to be careful not to forget that.
Jean Magmer, City Club member. Can you ask the question in high school health clinics? And What are you doing to work with those health clinics and those teenagers?
This, as an initiative, the One Key Question initiative, is focused on women 18 to 50. In order for us to change the healthcare delivery system, let us change it where the most women will be affected. As you heard earlier, teen pregnancies are declining. And I understand, believe me, I started in reproductive health over 40 years ago working with pregnant teenagers. So it grabs my heart, and it grabs me for all the kinds of reasons it grabs you. But we want to see this initiative become institutionalized, to become part of the way healthcare is delivered. If we focus on adolescents, we are also raising all other kinds of questions relative to parental consent, parental involvement. If we can't get this done for women 18 to 50, then we can't get it done. If we can get it done, I think it will be relatively easy then to see it introduced into school health clinics. Thank you for that question.
I'd like to read a question from one of the index cards here, and it maybe builds on that. You talk about asking women about reproductive health, but what about asking or having a similar conversation with our men?
What a great segue from the last question. Same thing. We wanted One Key Question to be asked of men and women. And in fact, I want to credit the Oregon Medical Association. When they endorsed this initiative, they would not endorse it just for women. They endorsed it for women and men. Again, please let us get this institutionalized for women, and then we will be happy to have it happen with men. Right now at Outside In, the question is being asked of men and women. Any clinic that is doing this or any provider that's doing it is free to do it to men. But as an initiative that we are promoting, we are focused on 18 to 50-year-old women.
Ted K., City Club member. What's Obamacare have as an effect on this? Are there provisions in the Affordable Care Act that encourage or discourage the goals that you're trying to accomplish? All three of you can answer.
You can go first.
Thank you. We had started this One Key Question initiative, and then the Affordable Care Act had a group, a nonpartisan group called the Institute of Medicine, identify what the essential health benefits should be within health insurance plans. The Institute of Medicine called out preventive reproductive health services as essential prevention services for women. All health plans must cover contraceptive care at no cost, preconception care at no cost. The Affordable Care Act is the single greatest piece of legislation for women's health in decades.
I would add one other point to that, which is the fact that there's guaranteed issue now that people can't be denied healthcare coverage for pre-existing conditions is a critical piece of this as well. I was going door to door a couple of years ago and talked to a woman whose granddaughter had been denied health insurance because she'd had acne as a teenager. That was a pre-existing condition. Now tell me any teenager who hasn't had acne, right? And probably asked their doctor about it, and therefore it's somewhere in their medical record. So that young woman was denied access to health insurance, and therefore, unless she took advantage of the great services at Planned Parenthood, may well have been denied access to preventive reproductive health care. So just guaranteed issue alone, in combination then with everything that Michele mentioned, is a huge advance for all of these things. And it means that we know that women and babies are automatically on health care coverage right away. So we don't have to go through all the paperwork of getting people enrolled and when they get pregnant. They've got health insurance already, which means they're more likely to get the preconception counseling they need and have a healthy pregnancy.
Greg McPherson, City Club member. By many measures, the rest of Oregon has fallen further behind the metro area in various economic categories. Could you comment, please, on what the reality is for maternal and reproductive health services out in the rest of Oregon?
I'll start with that if I can. You know, Michelle was talking about the siloing of healthcare for women. I will admit to a certain bias, but I'll argue that if we had more family doctors, that'd be less true. Because those of us who are family physicians do what we call womb-to-tomb medicine. And we do that reproductive health care for women just the same as we take care of acne or high blood pressure or early development in children. We need to be expanding the access to affordable primary care across the state, and that means comprehensive. We've done a bunch of stuff. Actually, in the 2013-15 biennium, the state of Oregon is investing more than twice as much as it has in the preceding 20 years in programs to help people headed toward primary care professions, family medicine, general internal medicine, nurse practitioners, PAs, headed in those directions for loan repayment or loan forgiveness programs than it ever has. $7.5 million, maybe even we got a little bit more in this year, in this last short session, almost $8 million, which is more than twice as much as we'd had in the preceding 20 years. Now that's, as Michelle said earlier about something else, necessary but not sufficient. We still have a huge healthcare workforce shortage in this state, and that's particularly true in our rural areas. And in those areas, teamwork is also really, really important, and great communication between the healthcare providers and the people who deliver human services, mental health care, dental care. That's going to be critical. So we're going to have to continue to build our interprofessional teams so that we are sure that nobody's falling through the cracks.
I think the piece that I would add to that in terms of our experience is that rural women do have a real challenge when it comes to simply accessing providers, and certainly providers they could afford. Now, pre-Affordable Care Act, where there might have been a clinician, close to them in a town, but it wasn't affordable. In order to get contraceptive care or preconception care, they had to find a way to get themselves hours away to a family planning clinic, public health program, a Planned Parenthood, or a safety net clinic. So that with the expansion of Medicaid vis-a-vis the Affordable Care Act, we are seeing an expansion of access to the low-income women and rural women who are most in need of these services. They have been disproportionately affected by the scarcity of providers and the geographic distance.
We also know that there's been a big increase in poverty all over rural Oregon, and to the extent that we know that economic factors influence health, the state of health in mothers and babies, it's easy to see in some ways why rural women and babies might be falling behind.
Unfortunately, we've run out of broadcast time for further questions, and we'll have to stop for the day. And as we close, please join me in offering our sincere thanks to Shelia Martin, Michele Stranger-Hunter, and Senator Elizabeth Steiner Hayward. Thank you very much. We are adjourned.